Very good evening. I welcome you all to another Journal Club edition of the Classroom series in association with Neurocritical Care Society of India. Today we have with us Dr. Swati. She is presently a DM student at AIMS Rishikesh. She'll be presenting the early drain trial. Over to you, Swati.
Thank you, ma'am, for the introduction. Today's topic is about the early drain trial. This is the effectiveness of the lumbar cerebrospinal fluid drain among patients with aneurysmal subarachnoid hemorrhage, a randomized clinical trial done by Stephen Wolf et al., which was published in the JAMA Neurology Journal online in June 18, 2023. Introduction. Subarachnoid hemorrhage from the rupture of an intracranial aneurysm is a type of stroke leading to death or permanent disability in most affected patients. Cerebral vasospasm, triggered by the amount of the blood in the basal cistern, was regarded as the causal for the delayed cerebral ischemia. Approximately 70% of the patients with subarachnoid hemorrhage develop vasospasm, up to 40% experience secondary infarction, and part of these without vasospasm. Prophylaxis with the calcium channel blocker nimodipine does not affect the cerebral vasculature but lessens the poor outcome by one third. It is a common standard to occlude the culprit aneurysm either by surgical clipping or endovascular coiling within 24 to 48 hours after hemorrhage, with coiling being preferred if both methods are equally feasible. This is done, and efforts to remove the blood in the basal cisterns as the causative agent for vasospasm, either by surgery, cisternal, or external ventricular drainage, showed mixed results. In retrospective studies, such as the Ulu et al., which is published in the World Neurosurgery in the year of 2022, the prophylactic lumbar drainage of the cerebrospinal fluid was associated with the favorable outcome. A plausible mechanism of action is the increased removal of the blood and its degradation products using the gravity by the lumbar drain. However, the prospective LUMAS trial, that is lumbar drainage in subarachnoid hemorrhage, randomizing 210 patients, was unable to confirm this benefit of the lumbar drains. In hindsight, this LUMAS trial recruited the less severely affected patients with the lower risk of adverse outcomes, which may thus have been underpowered to detect the significant effect. This is the picture showing the lumbar drain. The red color one is the lumbar drain, and the slight yellowish is the external ventricular drainage. You can note the difference between the two. That is lumbar drain, more red cells have come. Methods. It is a pragmatic, multi-center, parallel group, open-label, randomized clinical trial with blinded endpoint evaluation performed in 19 hospitals in Germany, Switzerland, and Canada, which followed the concert reporting guidelines. And the lead ethics approval was obtained from the Research Ethics Committee of the University of Erlangen, Germany, and the trial was approved locally from the corresponding ethics board at each participating center. If possible, written informed consent was obtained from the patient before the aneurysm treatment procedure. If patients were unable to consent, a legally authorized representative was asked for the permission. And the first patient enrollment was done in the year 2011 in January, and the last one on January 24, 2016, and follow-up of this trial ended in July 2016. Inclusion criteria for the trial included age more than 18 years, first aneurysmal subarachnoid hemorrhage, and pre-morbid modified Rankin scale of 0 to 1, and aneurysm treatment performed in the first 48 hours and with informed consent. Exclusion criteria were subarachnoid hemorrhage other than aneurysmal origin and no hemorrhage visible on CT, pregnancy, contraindications for the treatment with lumbar drain such as absent or compressed basal cisterns on the admission contrast setting, life expectancy less than 1 year for other reasons other than the current subarachnoid hemorrhage, other concomitant severe disease that would confound with the treatment. Objectives of the study was to investigate the effect of a early lumbar CSF drainage among the patients with the ruptured cerebral aneurysm. Hypothesis was that early application of a lumbar drain leads to an improved outcome after subarachnoid hemorrhage measured by MRS score at 6 months. This is postulated due to the diminished incidence of the cerebral vasospasm and delayed cerebral ischemia. The primary endpoint was rate of unfavorable neurological outcome, which is measured by modified Rankin scale at 6 months. This was dichotomized to either 0 to 2 as good outcome or 3 to 6 as unfavorable outcome. The secondary endpoints of the study were the rate of mortality in both the groups, Barthel score, and the Glasgow outcome scale extended at 6 months, and rate of vasospasm, rate of infarction due to the vasospasm at discharge, and requirement of a permanent ventricular peritoneal shunt, and rate of infections. This figure shows the protocol of the study algorithm, in which the aneurysmal subarachnoid patients within 48 hours they have undergone treatment, and post that it was randomized to either lumbar drain or the control group with the no lumbar drain, and the CT scan on the first post operative day, post treatment day 1 has been taken. According to that, drainage was done in the lumbar group with the around 5 ml per hour, and in both the groups, if necessary, EVD was inserted. And on day 7 to 10, the vasospasm was evaluated imaging by through imaging by CT scan or angiography, and CT scan was done before discharge to determine the infarction. And the follow-up of the patients was done up to death or at 6 months. The conduct of the study, emergency treatment on admission using the intubation and or placement of an external ventricular drain was at the discretion of the local team. Performed aneurysm treatment with the coiling or clipping as applicable and per local standard and in concordance with the international guidelines and recommendations. In case of randomization to the lumbar drain group, a lumbar drain was placed in a sterile technique after aneurysm treatment. Lumbar cerebrospinal fluid diversion was started after a post-procedural CT scan indicated safety. A rate of 5 ml per hour was recommended for the first 8 days, and protocol compliant treatment required at least 4 days, resulting in an equivalent of 480 ml of lumbar CSF drainage for per protocol analysis. Additional diversion via the EVD was at the discretion of the local team. ICP monitoring was performed as per the local standard, and zeroing of both ventricular and lumbar drains was similar on the level of the external acoustic channel. In case of more gradient, that is difference of more than 5 mm of mercury between both drains, or ICP level is greater than 20 mm of mercury, they recommended to postpone the lumbar CSF diversion for the safety reasons. And daily TCD monitoring was performed. In case of any suspected vasospasm or routinely on day 7 to 10 after the initial SAH, vascular imaging either via CT angiography or magnetic resonance angiography or conventional DSA was scheduled. And if any confirmed vasospasm is there, treatment included balloon angioplasty or local intraarterial vasodilators according to the local investigators. Due to the interventional character of the trial, the blinding of the acute caregivers, except for the local radiologist, was not possible in this study. The main secondary endpoint was the rate of secondary infarctions not being present in the post-procedural CT scan was performed after the aneurysm occlusion, and secondary infarctions were diagnosed with the last cerebral imaging either by CT or MRI before discharge from the acute care, and radiologists evaluating the scans received no information on the treatment groups. Statistical analysis was performed with the R version 4.1.0, and the group differences of categorical variables were tested with the chi-square test. Continuous variables are reported as medians and interquartile ranges, and testing was performed with the Mann-Whitney test. Intention to treat analysis included all patients meeting all inclusion and without exclusion criteria, regardless of their actual treatment. Performed additional sensitivity analysis in patients treated per protocol and as treated. They used logistic regression for the analysis of the primary and secondary endpoints to allow for the easy expansion to multivariate assessment. Odds ratio were transferred to risk ratios for more appropriate interpretation, and analysis on the dichotomized MRS scores were performed both unadjusted and adjusted for the age, untest grade on admission, and presence or absence of the intraventricular and intraparenchymal hemorrhages as relevant confounders. Statistical models were compared using the minimized archaic information criterion. Mortality between the groups was compared with the Cox proportional hazards. A two-sided p-value of less than 0.05 was used to indicate the statistical significance. The console diagram shows here the 307 patients were randomized, in which 155 were randomized to lumbar drain and 152 were randomized to the standard of care. In the lumbar drain group, 11 patients were excluded due to the consent and anticoagulation and late aneurysm treatment and not having any source data. In the 144 included in the lumbar drain group, 109 treated per protocol, but 35 patients had protocol deviations due to the lumbar drain was not inserted in the scheduled time, or there was an error, or the data was missing, and hence for the final 144 was included in the primary outcome analysis. In 152 patients who were randomized for the standard of care, 9 were excluded again due to the consent, anticoagulation, or no data, or died before the treatment. And one out of 143 which were included in the standard of care, 141 is treated per protocol, and 2 were protocol deviations due to the misrandomization, and the lumbar drainage was inserted in such patients, and hence 143 included in the primary outcome analysis. The baseline characteristics of the patients: of 287 included patients, 197 were female and the median age was 55 years. A total of 287 randomized patients were analyzed according to the intention to treat principle, with 144 in the lumbar drain group and 143 in the standard of care group. You can see the female patients are more in both the groups, and until classification, the 1 and 2 are relatively more in the lumbar drain group, and poorer grade are more in the standard of care. And even the intraventricular hemorrhage patients, 90 are in the lumbar drain and 85 are in the standard of care group. And more common aneurysms are the anterior circulation aneurysms in both the groups. Results: in the lumbar drain group, 109 patients, that is around 75%, received a lumbar drain after the aneurysm treatment with drainage as specified. So a total of 141 patients in the standard care group were treated according to the protocol. 2 received the high volume lumbar drainage as specified for the lumbar drain group in the standard group. So all crossover patients were kept in the intention to treat analysis in the randomization groups independent of the actual treatment. And patients from both the groups with drainage as specified were looked at the per protocol sensitivity analysis, while actual treatment was investigated in the as treated analysis with a threshold of 480 ml lumbar drainage, that is around 5 ml per hour in the first 8 days, to separate between the groups. So in the primary endpoint, MRS score of 3 to 6 at 6 months, that is unfavorable outcome, was more in the standard of care group, which was significant, with the relative risk of 0.73. And in the secondary outcome, the infarct at discharge again was more in the standard of care group, that is the patients without the lumbar drain, which was again significant. But there was no significant difference in the vasospasm between the lumbar drain and the standard of care group. And mortality at 6 months, measured by the Glasgow outcome scale of extended and Barthel index of less than or equal to 80 at 6 months, both were more in the patients who does not have the lumbar drain, which was again significant. And infarct at discharge and MRS score at 6 months per protocol analysis was also more significant in the standard of care group. And even as treated group also, infarct at discharge and modified Rankin scale score of 3 to 6 at 6 months was more in the patients who does not have the lumbar drain, which was again significant. Patients in the lumbar drain group received a median daily lumbar drainage of 108 or of 92 to 118 ml in the first 8 days. A total of 102 patients, that is around 70.8% in the lumbar drain group, and 110 patients, that is around 76.9% in the standard of care group, had an external ventricular drain installed. And median daily fluid drainage via the ventricular drain was lower in the lumbar drain group. And patients in the lumbar drain group showed a lower ICP. No differences were noted in the mean daily arterial pressure, fever burden, transcranial Doppler hemoglobin levels, fluid intake, and fluid balance in both the groups. And no differences between the lumbar drain group and standard of care group were observed in the frequency of vasospasm, which was diagnosed clinically. That is 41 in lumbar drain versus 48 in the standard of care group via TCD. 36 in the patients in the lumbar drain group versus 31 in the standard of care group, or diagnosed with the angiography around 52 in the lumbar drain versus 48 in the standard of care group. These were non-significant. And 10 patients in the lumbar drain group and 14 patients in the standard of care group were treated with either balloon angioplasty or intra-arterial vasodilators as rescue therapy for vasospasm. The primary endpoint, which was measured by the modified Rankin scale at 6 months, no patient was lost for evaluation at the primary endpoint. In this figure, you can see the lumbar drain group and the standard of care group. The 0 and 1 is the favorable, up to 2 is the favorable outcome, and 3 to 6 are the unfavorable outcome. And the percentage of the patients with the favorable outcome are more in the lumbar drain group as compared to the standard of care group. In the standard of care group, the percentage of the patients with the unfavorable outcome, that is from 3 to 6, are more in the patients who does not have the lumbar drain. So in the intention to treat analysis, 47 of 144 patients in the lumbar drain group and 64 of 143 patients in the standard of care group had an unfavorable outcome at 6 months, unadjusted relative risk of 0.73 with the 95% confidence interval with absolute risk difference of minus 0.12 and p-value of 0.04. In the secondary endpoints, a total of 41 patients, that is around 28.5% in the lumbar drain group, and 57 patients, that is 39.9% in the standard of care group, experienced a secondary infarction seen on the last cerebral imaging scan before diagnosis, with unadjusted relative risk of 0.71 in the 95% confidence interval with absolute risk difference of minus 0.1 and with the p-value of 0.04, which was significant. And 19 patients in the lumbar drain group and 25 patients in the standard care group died within the 6 months. But there were no differences in the causes of death between the groups, and no patient died due to the complications related to the lumbar drain. And rates and places of discharge were similar in both the groups, and no difference was seen for the rate of the permanent VP shunt procedures. In the subgroup analysis, they have done the subgroup analysis, and the forest plot here shows the moderate grade and the high grade disability unfavorable outcome that is measured by the MRS at 3 to 6 months, which favors the lumbar drain, and more unfavorable outcome were present in the standard of care group. The effect of the lumbar drains on the primary outcome was consistent across the pre-specified groups. Endpoints for sensitivity analysis were the rate of infarctions at the discharge and long-term unfavorable outcome. Analyses were performed unadjusted and adjusted for the baseline imbalances in age, untest grade, and intraparenchymal and intraventricular hemorrhages, and all outcomes in the sensitivity analysis were in favor of the lumbar drain group. Adverse events of the study: one patient was reported to develop an increasing gradient of more than 5 mm of mercury in ICP readings from the EVD and the lumbar drain, which prohibits for the continuation of the lumbar drainage. And one patient developed a local skin infection at the site of the lumbar drain requiring the surgical excision. In another patient, the lumbar drain was torn off requiring the surgical removal, but there was no difference for the rate of the suspected infections. In the multivariate analysis, the presence of the external ventricular drain was the only risk factor associated with the development of infection. The post hoc analysis was done for vasospasm detected by the clinical means, TCD, or with angiography, was associated with the rate of infarctions at the discharge, and infarctions at discharge were associated with the unfavorable outcome at 6 months. So, in the early drain trial involving the patients with the aneurysmal subarachnoid hemorrhage of all grades, the use of a lumbar drain in addition to the standard of care resulted in less infarctions at discharge and decreased the rate of the unfavorable outcome as measured by the modified Rankin scale at 6 months. The amount of the CSF drained in the first week was similar in the lumbar drain and the standard of care groups, and the color difference in the fluid from the ventricular and the sorry from the ventricular and the lumbar drain when both are used simultaneously is visual striking. As the lumbar drain, more red cells are seen due, and in the ventricular drain the red cells are very few or it is not visible to the naked eye. And erythrocytes in the CSF tend to sediment by the weight, rendering their removal by the lumbar drain more feasible than by an external ventricular drain. Hence, the patients in the lumbar drain group were noted to have significantly lower ICP. Approximately 80% of the patients with the SAH exhibit intracranial hypertension above 20 mm of mercury at least once, and unfavorable outcome is linked to the duration and the magnitude of the ICP elevation. Early drain trial data indicate that the way of the drainage matters, and lumbar drains are more efficient in attenuating the intracranial pressure. Vasospasm, regardless of its definition, was associated with the development of secondary infarctions. The lumbar drain and the standard of care groups differed in the rate of the secondary infarctions but showed the similar vasospasm frequency and severity. The techniques like local brain tissue oxygenation monitoring, detection of cortical spreading depolarizations, or continuous surface electroencephalography recordings may provide further insight. Data from the traumatic brain injury show that cautious lumbar drainage may be used for the treatment for the refractory intracranial pressure, and safety concerns based on the clinical and imaging judgment only led to the crossover in several patients from the lumbar drain group to the standard of care group. Hence, the authors proposed to monitor the intracranial pressure simultaneously on lumbar and ventricular drains. When there is a lack of gradient between both the pressure, which indicates the open cerebrospinal fluid pathways, and hence the safety of the lumbar drainage increases. The rate of infections in this trial reflects a mixed grade aneurysmal SAH population. The definition of infection in this trial was included, but it was not specific for the device associated meningitis, which would have required frequent CSF analysis, which itself would have triggered the infections. In fact, detection at discharge was mainly performed using the CT in this trial, as they preferred neurological worsening, which was judged by the clinician in charge, and an imaging method separately. The rate of infarctions was higher in this trial than in other contemporary works, and key differences to other studies was the inclusion of the patients with the poor grades, Hunter's grade 5 and or WFNS grade 5 in this trial, which were excluded elsewhere. The limitations of this study was which this study was unable to secure funding to allow timely completion, prohibiting the hiring of dedicated personnel because the first protocol was published in the year 2012, and patients, relatives, and acute care clinicians were not blinded due to the intervention. Although this may be a source of bias, but blinded outcome assessment of the radiological imaging and clinical status at the 6 months minimize this potential, and they did not collect the data on pre-existing hypertension and other pre-morbid prognostic factors. There was no detailed information on the thickness of the clots or the amount of the intraparenchymal and intraventricular blood in the initial CT scan. They did not record the medical complications during the clinical course, which happens frequently in patients with the subarachnoid hemorrhage, and they did not investigate the additional application of the clot thrombolysis or irrigation of the subarachnoid space, and they were unable to evaluate the benefit of the possible higher drainage rates than the suggested 5 ml per hour, although some patients did have a higher drainage amount via the lumbar route. To conclude, in patients with the aneurysmal subarachnoid hemorrhage, prophylactic lumbar CSF drainage is warranted to lessen the burden of infarction at discharge and to reduce the rate of unfavorable outcome at 6 months. And hence, these findings support the use of the lumbar drain additional to the standard of care for the aneurysmal subarachnoid hemorrhage patients. So, to conclude, this 90 men and 197 women, the trial undergone in the 287 individuals, randomized to either the lumbar drain group or the standard of care group, and which favor the lumbar drain group due to the more of MRS 3 to 6 of unfavorable outcome were more in the patients who does not undergo the lumbar drain, that is in the standard of care group. And a similar trial, that is the lumas trial, in which they also randomized for the lumbar drain placement in the aneurysmal sh, and they measured the outcome by modified rankin scale of 456 at day 10 and 6 months, and they also showed the lumbar drain reduce the prevalence of the delayed ischemic neurological deficit and improve the clinical outcome, but again failed to improve the outcome at 6 months after aneurysmal sh. The difference is due to the lumas trial included only the less severe grade patients, and hence it would have been underpowered. Critical appraisal. Did the study has a clearly focused question or issue? Yes. Is the research method appropriate for answering the research question? Yes. Does the study add anything new? Yes. Were there enough subjects in the study to establish that findings did not occur by chance? Yes. Was the selection of participants based on external objective and validated criteria? Yes. Was the subjects representative of a defined population? Yes. Was the study performed according to the original protocol? Yes. Was blinding of the investigators done? No, only the radiologists in the studies were blinded, but the clinicians and the patients were not blinded. Was the follow up of cases long enough? Yes. Were all participants' data analyzed in the group to which they were randomly allocated? Yes. Or objective and validated methods used to measure the outcome? Yes. Is size effect practically relevant? Yes. Were the confidence intervals given in the study? Yes. Could there be confounding factors that haven't been accounted for? Yes. Can the results be applied to our organization? Yes. Thank you.
Thank you, Swati, for that very nice run through of the early lumbar trial. Okay, so just a few questions. You have already covered most of it, and earlier, with regard to lumbar drain, we did have the Loomis trial. So, based on this trial, will your practice change in application of practically what are all the issues when we put in a lumbar drain this early in our patients?
Ma'am, when we put the lumbar drain, if there is no ICP monitoring in the institutions, it will be very difficult because there is a problem of over drainage of the CSF if it is not monitored properly, and there may be downward herniation of the brain parenchyma also. So those things should be kept in mind. But again, 5 ml per hour drainage with ICP monitoring and with simultaneous EVD, if the gradient is less with the open CSF pathways on the CT, we can institute the lumbar drain in these patients.
Okay. What do you think is the major limitation of this trial? So you have mentioned all the limitations of this trial. It is a very one of the longest trial. I think we started
Yes, ma'am.
expecting results. Each DM student would have thought, okay,
Now,
for my exam, will it come? And I think for your exam, it has finally come. So what do you think is the major, limitations when you look at the patient population they have included?
in the lumbar drainage group, they have included more of the better grade patients than the worse grade patients, which would have been a bias for the outcome. But they have done the adjusted in the later on for the multivariate analysis by including the models, which would have been lessen the bias, but still it is the bias is there.
And yeah, the most important complication in this case is the over drainage. So there can be a herniation possible, re-rupture possible if the aneurysm is not secured because of rapid pressure changes. And it goes into the hypothesis of more the SAH, more chance of vasospasm. Okay, so that is one thing. But What other trials have come positive with regard to SAH except nimodipine? I think this is one of the trials which has come positive.
Yes,
Okay,
ma'am.
so and another important thing is the infection rate with the lumbar drainage. So in practice, like how long should the lumbar drain be kept based on this trial? What would be your take home on that?
They have written the infection rate which was higher in the observed in the lumbar drain group is mostly due to the lumbar drain itself rather than the patient characteristics. So lumbar drain is associated with the infection rate is still there, but sterile application and care of the patient, dressing, wound dressing, and care of the site, entrance site, if we take care of that, I think with the antibiotics we can reduce the infection rate, but still infection risk is there in these patients.
Okay. Those were all the questions raised. Thank you very much, Swati, for this journal club, the early drain trial. Thank you very much on
Thank,
behalf of CSI Classroom Series. We wish to see you more on these forums. Thank you so much.
thank you, ma'am, for me giving me this opportunity. Thank you, ma'am.